Hi, good evening, everyone. Welcome back to our webinar after maybe 2 to 3 weeks without me in town. I was in UK, my daughter got married. And today I welcome back Dr. Lau, who gave us a talk on hepatitis B. So fascinated with her smile and her great lecture that I had to invite her back for this topic that I can't even say is too much of a mouthful. I can only remember fatty liver. So maybe without wasting any more time, we'll just ask Suyin. Suyin, maybe you can start.
Okay, thank you. I will share my screen, or is my screen shared already?
Not yet.
Not yet. Nah.
Okay.
Okay, can you see my slide now?
Yes.
All right. Thank you, Betty. Thanks for the invite. Always a pleasure to come on this platform.
So happy to see you. I just love watching you. Okay, go on.
Thank you. So as Betty said, it's becoming a mouthful, metabolic dysfunction-associated steatotic liver disease. So it's almost like asking us to do she sells seashells on the seashore.
Yes, exactly.
So for better, I mean, nowadays we just name it meso-D lah. In the past, we talked about methyl-D, but now we talked about meso-D. And hopefully for the next 1 hour, I will be able to share with you why we are so concerned about this liver disease, why we are afraid that there's a tsunami of meso-D coming to Malaysia or in the world. And so hopefully we are more vigilant in looking for this lah. So I thought it would be appropriate because actually there is a French delicacy which literally translates to fatty liver.
Oh, yes.
So I thought maybe I'll bring this poll up and see, just for the fun of it, because I had no idea that.
How do we do this? We just use our phone, is it?
Yeah, use your phone and then scan the QR code.
Okay.
If you can't scan the QR code, then you can join at slido.com lah.
Okay. Can scan the QR code. It's very yummy, actually. Not much of it, but it's very yummy.
Yeah, you can have it fried, you can have it baked, you can have it with other things.
So how come only 2 people? Come on, guys. There are 60 people here and more watching from the. I'm sure. Just use your phone and then scan the QR code, and then you will actually can answer. Yeah, never mind lah. So
still warming up lah. Maybe we're still warming up.
Okay, no fun lah, you guys.
That's okay. That's okay. So I think we'll move on now. 100% for grass. So that's really good. 5 people and the number will come. I think maybe there's a bit of a lag or so lah. Wherever we are. So sometimes internet's not that fast anymore. Okay. So over the next 1 hour, this will be my outline for the talk. I would show you as to how it evolved from becoming NAFLD to MEFLD to now MESO-D. What's the diagnostic criteria for fatty liver disease? I'll use this term loosely because we're not currently doing a research, so I can just loosely say this is fatty liver disease. When and why do we need to screen? Why are we so worried about this? How do we actually screen for it? Because nowadays we avoid doing liver biopsies. When I was training, I was doing liver biopsies. Every time I do a liver biopsy, I get a cringe. Yeah. So we don't really like doing liver biopsies unless we absolutely need to. And so in fatty liver disease, we don't really do them anymore. And what sort of advice do we give? How do we give the advice? Because a lot of us would just say diet and lifestyle management, but actually to come down to the nitty and gritty details as to what diet and lifestyle should people do. What are the medication options out there that we can start? And of course, last but not least, when do we need to refer on to secondary and tertiary care? Because honestly, majority of these patients can be looked after in the primary care setting. And hopefully I would tell you as to how to do it. So this author made a very nice summary and looked back 200 years of history of how they discovered fatty liver. So Thomas Edison, 1836, discovered fatty liver.
History channel. Okay, go on.
Yeah, and it's
Sorry.
very interesting, you know,
Yes.
Betty, reading this paper, they quoted in the 1849 how they wrote the paper.
Okay.
So fatty liver is a consequence of a luxurious and indolent regimen. They also found it in children gorged with food, and it's especially found as a result of dram drinking. I had to look what dram drinking up. It's actually whiskey drinking. So they call it dram drinking.
This must have been a diagnosis made post-mortem, right? I'm sure there was no.
Yeah. So sometimes clinically, sometimes in the mortuary. So in the past, I mean, they do a lot of all these research, cutting people up and cadavers up, and seeing what's going on. So this guy, George Butt, also said that liver failure fatty liver is found in persons who are gross feeders. The liver is extremely fatty in men who take little exercise and drink immoderately of ardent spirits. He also came up with a management plan already in 1857. So he said, if he will rise early, take active exercise, abstain from butter, bacon, oil, beer, and not eat too largely of sugar and starch. And these patients will cure. So that is the diet and lifestyle management dating back to 1857. So it's very interesting, Betty. I think it's very, very interesting.
Amazing. And this Thomas Edison is not the Thomas Edison who invented light, right?
No, I don't think so.
E, right?
Yeah, that's a different one. But Betty, you'll be familiar with this guy, Austin Flint. I remember the Austin Flint murmur. I didn't know he dabbled in liver.
I forgot completely about the murmur because nowadays we don't even listen to the heart murmur.
That's true. I still teach in medical school, so I still have to describe what Austin Flint murmur is. So he said that food and indolent habits conduce to the accumulation of fat in the liver, the mechanism being the same as in the production of foie gras of geese. So basically just force feeding these geese to make their liver fat so that we can eat them. It's like how we get fat. So that is in the 1860s, 1870s, and then only in 1970s or 1980s, they found out that actually non-alcoholics also have fatty liver. So then they found out that non-alcoholic fatty liver disease exists, and named it as NAFLD at that time. But in 2020, Muhammad Islam in Asia Pacific also noticed that actually we don't want to exclude alcohol in fatty liver disease. We think that there's a specific type of people or phenotype that would have MAFLD, so patients with metabolic syndrome. So they wanted to change it from NAFLD to MAFLD. And so we have adopted MAFLD in Malaysia as well. So that is in 2020. Since then, we've been using MAFLD. But last year, obviously, the Europeans said that, okay, NAFLD is not great. The Asia Pacific region has come up with MAFLD. We have to change also. And so they came up with MASLD.
I see.
Yeah, so that's how it evolved from being NAFLD to MAFLD to now MASLD.
So why do we follow them then? Why don't we just stick to ours?
I mean, it's more widely used, I guess, Meso-D in the Western world. You can still use Mefo-D, but we are just keeping up with the times. And Prof. Chan Wah Keong wrote this paper that was published last year, keeping up with the times also. So he wrote this very nice review paper as to what Mefo-D and how Meso-D and how the change of nomenclature has affected us. But basically, if you look at Mefo-D and Meso-D, it's pretty much the same thing. Basically, it has steatosis, so fatty liver, either found on ultrasound scan or with some biomarkers or on biopsy, which we don't really do nowadays anyway. Plus one of the following metabolic risk factors, looking at their weight, their BMI, looking at whether they have pre-diabetes or diabetes, looking at their lipids, and looking at their blood pressure. So the parameters are pretty much the same as to how we diagnose people with Mefo-D and Meso-D. So to me, it's the same thing. The criteria comes more strictly for researchers, because if they want to develop a drug, which we will talk about later as well, they need to make sure they have the right population, the right cohort that they can trial these drugs on. That's why it gets a bit more tricky with the criteria. So in that sense, it makes a huge difference. So for Mefo-D, why are we worried? It is a global epidemic in the making. So this paper was published 5 years ago now. 5 years would make a lot of differences. At that time, they found that 30% of the adults worldwide have Mefo-D or Nefo-D at that time. And over a period of 10 years, the prevalence of Mefo-D went from 22% to 37%, which is about 15% increase, a lot in 10 years. So sometimes you think, okay, 15% is not that much. But then if you think about the liver-related complications and all the other complications associated with fatty liver disease, it is a huge burden on the healthcare and economy as well, because these patients would have a lot of other complications. So this was published in the National Health Morbidity Survey last year, that the keywords are there. We are getting fatter. So you can see that 54.4% are quite fat. So there's no better way of saying this, but we are getting heading towards a fat nation. It's very obvious, because if you were to go out to have your tea, your breakfast, your lunch, your dinner, people watch, which I often do anyway, people walking past and walking by, you can see 1 out of 2 people are a bit more rounded in the waist area. They may not be very, very round. Some may be very round, but a lot of us would be prosperous because we have so many choices of food. So that's why we are getting quite worried.
I think you're being kind. I think a bit round is not right. I believe that, okay, when I was young, and I'm old now, okay, so when I was young, women used to be smaller than men, and young adults used to be thinner than old adults. It's normal, but now it's the other way around.
Correct.
Young adults are bigger than old adults, and that's me. And women are bigger than men. And we're talking about not 5 kg overweight or 6 kg. We're talking about 30, 40 kg overweight in our society. And it's just shocking as the amount of weight that is going up by the year. I'm so sorry. I can't take it. You can go on. Sorry.
That's okay. Understandable. That's why it is such a big problem. Again, this paper, this survey showed us that 2 in 5 people have metabolic syndrome, 3 in 10 people has fatty liver disease. So if you look at the absolute numbers, 6.7 million of the population in Malaysia would have fatty liver disease. 6.7 million. That's a lot of people with
Yes.
fatty liver. So that's why a lot of my colleagues have started saying that this is a tsunami of fatty liver disease. A tsunami is coming.
Tsunami of fat. Can you imagine? Water also we can't take it. Tsunami of fat. Tsunami of fat. Go. Sorry.
So brings us to the burden of this disease, MESO-D and MASH. So MASH is the more severe form of MESO-D. So it increases the risk of fibrosis progression. There is a lot of inflammation in the liver that's driving the fibrosis. So we know that the stages of liver damage goes from a healthy liver to liver cirrhosis. And I'll go through the different stages as well. But in a patient with MESO-D, most of the time, if they don't have any complications of liver disease, they are asymptomatic. So unless they go to get a blood test to say that, okay, maybe the liver enzymes are a bit abnormal, they may not come to hospital until they get liver cirrhosis and decompensated cirrhosis or hepatocellular cancer, liver cancer. Over the last 1 week, we've had 2 patients coming into UPM with liver cancer, with undiagnosed fatty liver in the past when they were younger. So very, very sad cases, which we hopefully would try to change, and you would help us to change after this talk. So the other real reason as to why we're worried, it's not just the liver. Betty, you have to be worried also because these patients have poorer cardiovascular outcomes. They would have ischemic heart disease, heart failure, cardiovascular related deaths. And for everyone, cancer also, not just in the liver, but outside the liver, it's associated with fatty liver disease. And I wouldn't go into the molecular side of things as to why this is the case, but basically there's a physiological aspect to this, lipotoxicity, insulin resistance, there's pro-inflammation, and that's why we get all these complications from fatty liver disease.
To all the women out there, also it causes infertility in a lot of cases, yeah.
PCOS
Yes,
is something that's associated with obesity.
Obesity, yes, that's right. Okay.
So when and who do we screen for MESO-D? I'm not asking you to, everyone that walks into your clinic to do an ultrasound scan, that's not really cost effective lah. So we would target a specific population to screen, those with metabolic risk factors, obviously the overweight, obese, and we also found that type 2 diabetics are at very, very high risk of having fatty liver disease. So again, studies have been done looking at the population that has type 2 diabetes. More than half of them would have fatty liver disease. And about 20% would have advanced liver fibrosis based on non-invasive tests, like fibrosis tests and things like that, which we will go through later. And when they biopsy these patients who have advanced liver fibrosis on these tests, 83% have the more severe version of fatty liver disease, NASH, and about 90% of them would have some degree of scarring of the liver. So type 2 diabetics, be very, very careful. These patients, we have to actively screen for MESO-D.
Can I ask you, can we go to the previous slide?
Sure.
Can I ask you, is it just the degree of the obesity that is causing both the type 2 diabetes and your liver fibrosis?
So there's no
Weight
real...
related?
Yeah, obesity itself does not correlate with how severe the liver fibrosis is.
I see.
Type 2 diabetes seem to be associated more with the risk of progression. So it's not really obesity associated with progression of liver disease, but type 2 diabetes itself.
I see. So not the weight in itself the
No.
BMI in itself. Okay.
Correct. But I agree there's a domino effect. Obviously, if we are a bit more overweight, then sugars will be difficult to control as well. So they may have a domino effect with all those things. So now that we diagnose someone with MESIL-D based on the diagnostic criteria and on imaging, what next really? What can we do? What should we be thinking about? Two things. One is whether there's any liver scarring. So not all patients with fatty liver disease would have liver scarring, and those are the ones that we want to catch. And what is the risk of progression? Like Betty suggested, what really are we worried about? What are the patients that we need to look up for to say that these patients will progress to liver cirrhosis very quickly? So two things, liver fibrosis and what is the risk of progression. So when we talk about fibrosis stage, we have F0, which is no fibrosis, to F4, liver cirrhosis, the most severe form and irreversible form of scarring of the liver. So some clever people out there looked at all these patients. So in patients with just MESIL-D, so there's no inflammation in the liver, their progression of one stage is by 14 years. So they move from F1 to F2 in 14 years, F2 to F3 in 14 years, so on and so forth. But we have to remember that it's not a one-way, one direction. So it's a whole spectrum in terms of fibrosis. There's no clear cut, oh, you're in F2. There's no clear cut, oh, you're in F3. It's a whole spectrum. So, but we know that MESIL-D will progress about 14 years.
You hold on. I need to mute somebody. Okay, go on.
But if somebody has MASH, their progression will be faster in one stage in 7 years, half the time. So this is something that we need to worry about lah.
I mean, people might think that 14 years is not a long time, but if you start being overweight in your teens, 14 years is you're not even 30 yet.
Correct.
Yeah.
I mean, the 20s and 30s also in 14 years only
Yeah, that's
middle
right.
age.
Yes, yeah. Okay.
So I've
what's
put up this
thing?
poll as well, just to keep things a little bit more interactive. We have mentioned some of the risk factors, but we will mention more of that later. What do you think are the risk factors for progression of just fatty liver disease to liver cirrhosis? What do you think?
You mean
So I think this is a word cloud.
Ended one. Oh my God.
This is a word cloud. Type 2 diabetes, very good. Somebody's been paying attention.
Okay.
So if you've got phone, if you have your phone handy, you can scan the QR code. Or join at slido.com. Alcohol, very good. Very, very good.
That's me. Who loves to drink.
Metabolic syndrome, good.
Anyone else?
Any others? You can type a few if you want.
Yeah, just go on. Just
what do you think the risk factors are?
herbal remedies.
Herbal remedies? That's a controversial one. Obesity, okay. What else do you think would accelerate the fatty liver to become cirrhotic? What would pour oil to the fire?
Gets me thinking.
What would really, really pour oil?
Okay, let me try again.
So I'll give you a clue. Alcohol is also another cause for liver problems. Any other causes of liver disease? Some say hepatitis. Yes, if we can be a bit more specific, what sort of hepatitis? Age, okay. Dyslipidemia, high fat diet. Hepatitis A, B, and C. Hepatitis A, not so much because it's usually a self-limiting. Usually Hep B or Hep C. because that can cause chronic liver disease. Hepatitis A usually don't cause
Self-limiting.
chronic liver disease, correct. Hepatotoxic drugs, good, very good. I think due to the interest of time, I'll close this session.
Yeah.
So high risk of progression, we talked about type 2 diabetes and MASH. So if somebody has MASH, then it halves their progression time and they progress much faster compared to patients without MASH. Obviously, when we screen the patient, if the patient already has F2 fibrosis or advanced fibrosis, then their risk of progressing would be higher. So their fibrosis stage at staging. Any other coexisting liver disease, someone mentioned alcohol, viral hepatitis, especially hepatitis B and hepatitis C, and other forms of chronic liver disease can increase the risk of progression because you not only have one thing, the fatty liver, to attack the liver, you have other things that's just constantly causing injury. And again, that would make the liver go unhealthy very quickly. There's some genetic factors also, one of which is the most we are most aware of is the PNPLA3 genetic polymorphism. So these patients would have a higher risk of progression from fatty liver disease to liver cirrhosis as well. So how do we screen for fibrosis? We don't do a liver biopsy anymore. There are many, many blood tests out there that are very, very useful. Blood tests that you and I do routinely. So the AST, the ALT, and platelet count is very easily found on the liver function test and the full blood count and the patient's age. Then we can calculate this fibrosis 4 score or FIB4 score, which is the one that we use most often to see whether the patient has liver fibrosis or not in the context of MESIL-D. Obviously, this score can be used in other chronic liver disease as well, like hepatitis B and hepatitis C. I often use this score to see whether they have liver scarring or not. So FIB4 score, just if you remember one score, this is the score to go to calculate for liver fibrosis or liver scarring.
How did they come to use platelet in this scoring system?
So we know that once a patient have advanced liver fibrosis or cirrhosis, they would have portal hypertension, and that can cause low platelets. Sometimes it can cause splenomegaly as well, especially if those with portal hypertension, they would have splenomegaly, and that would cause thrombocytopenia. So that's why platelet count is being incorporated in this fibrosis score.
So when I learned that the liver cirrhosis, of course, can cause portal hypertension and after that splenomegaly, but this is not even at the stage of cirrhosis yet, right?
Correct.
So the changes starts very early. Even the portal hypertension starts even as early as before the cirrhosis happens.
Betty, because all these calculated scores are used to exclude patients with advanced fibrosis.
I see.
So it's not a good test to rule in.
Okay.
It's a very, very good test to rule out.
Okay.
And so this test is only used to rule out lah. So that's why if somebody has a normal platelet count, their AST and ALT level is normal, their age is less than 65 or more than 35, then we can confidently say that you don't have liver fibrosis or you are very, very low risk of having liver fibrosis. And so we can just monitor you instead of referring you on. So that's why the platelet count is in here. Obviously, if somebody has low platelets for whatever reason, if they've got a hematological problem and they have low platelet count because of that hematological problem, this score is not accurate anymore. So we just have to be mindful of that. So there are other blood based markers out there that are patented, which means that people have to pay quite a lot of money to get this test brought into the lab, which are out there. I think I remember seeing somebody coming in with an ELF test from a private lab, but they are not very often. So one test to go to, FIT4 score, it's free. You can calculate it, and it usually comes with all the blood tests that you routinely request for anyway. So it's a very good test to exclude advanced fibrosis, but this test is not to rule in advanced fibrosis, okay? So what do we do if the FIT4 score, let's say, is abnormal? Okay, so this is the cutoff scores that we look at. If the FIT4 score is less than 1.3, we can confidently say that significant fibrosis is unlikely. And so we just monitor you every 2 to 3 years. We repeat another blood test and calculate your FIT4 score and see what your FIT4 score is at that time. Because it uses age in the calculation, we would say that if the patient is 65 years and above, our cutoff is a bit higher at 2.0. So if the FIT4 score is 1.3 and above, we just need another test. The second test is to measure the liver stiffness. Again, we don't do liver biopsies, so there are other methods to measure the liver stiffness. And this is basically how we do a liver stiffness measurement. Use something, poke the liver go jelly-like. That's a good liver. Okay, so we use something called vibration controlled transient elastography. And there are a few machines out there, standalone machines, that basically just looks at the liver stiffness. They are FibroScan, FibroTouch, and more recently there's Hepatis out there. So these are the ones that I know of. But then there are some ultrasound machines out there that has an additional top-on software that looks at shear wave elastography. I'm not sure how common that is being used at the moment, because then the sonographers or the radiologist would have to learn how to do this shear wave elastography, and they can just measure the stiffness of the liver at that time. MR elastography is also a very good test, but obviously it's expensive and less available in the different settings. So FIT4, number 1, blood test, calculate the FIT4 score. If the FIT4 score is 1.3 and above, then we do a second test, which is a liver stiffness measurement. The go-tos are usually transient elastography. If we have the machine, great. If we don't have, we ask our radiologists and see whether they have shear wave elastography. If they do, they can pop that onto the area of measurement and give us a liver stiffness measurement as well. MRE, again, difficult to find, less available. So what do the FibroScan or the liver stiffness measurement scores mean? If the KPA or the liver stiffness score is less than 10, then it is unlikely to have advanced liver fibrosis. So we are very, very safe. If it's 10 to 15, we may have advanced liver fibrosis, but not very certain yet. They require a closer monitoring. Instead of 2 to 3 years, every year we'll have to repeat a test. Whether we are comfortable doing that in a primary care setting, we leave it up to you. If it's 15 and above, it is very likely that this patient has advanced liver fibrosis, in which case they will be prone to decompensation. They will be prone to having HCC. So these patients, we will often like to be referred to hepatologists. If it's 20 and above, then they say that these patients may have clinically significant portal hypertension. Clinically significant portal hypertension means that they may have varices, they may have ascites, and they will be very, very prone to decompensated liver cirrhosis. So these patients definitely recommended to refer to gastroenterologists or hepatologists out there as well. So there's one condition called lean meso-D. So I've got a few colleagues who are active, lean, but have done some ultrasound scan as part of their healthcare screening and found that they've got a bit of fatty liver. So again, you can see here It's not uncommon, you know. It's about 30% of the Asian population have lean meso D. And the main cause for this, or the most common cause for this, is that we have insulin resistance, or if we have visceral adiposity, so we are fatter on the insides. So this is the most common cause for lean meso D. So even if we are within the normal BMI range, 18 to 22, we are also at risk of having meso D because of these reasons. Obviously, if the patient has hit...
Can I ask, is it age-related?
No, I don't think it's age-related,
Okay.
Betty. I don't think it's age-related. So it's insulin resistance. We say age-related, do you mean like if we are middle age or a bit older, then we may find lean meso D? Probably. Definitely not in the teens lah. Don't think in the teens. Maybe when we get a bit older, we have insulin resistance, we tend to indulge more on fatty foods and accumulated more visceral adipose tissue. So then we get lean meso D. Infections, genotype Hep C and HIV, we will be more prone to having meso D, fatty liver. Some drugs also, tamoxifen, amiodarone, and diltiazem, and of course that genetic PNPLA3 mutation will cause meso D and progression of meso D as well, if we remember. So the recap so far, meso D basically is diagnosed based on imaging and what their metabolic risk factors are. And then once diagnosis is confirmed, we have to try to prognosticate them, decide whether they have no fibrosis, in which case we can happily manage, see them back in 2 to 3 years. If they have some fibrosis, we need a second test, a liver stiffness measurement. If they have cirrhosis, refer them on for management of their cirrhosis. So specifically for fatty liver management and MASH management, what are the goals out there? Obviously, to try to reduce or to slow the progression of liver fibrosis. If we can regress, like I said, chronic liver disease is a spectrum, so they can flip from F1 to F2, from F2 to F1 quite easily. So we want to try to regress their fibrosis stage. We want to reduce their cardiovascular risk factors because, as you remember, these patients are prone to having poor cardiovascular outcomes. We want to control their diabetes a bit better and also screen and manage all their other metabolic comorbidities. So the way to go is to lose weight. There's no better way of saying that. We have to lose weight. How do we ask them to lose weight? So UPM is very lucky because we have a one-stop metabolic clinic, in which case in that clinic, one patient will come and see different specialists altogether, an endocrinologist, a psychologist, because often there is some psychological aspect as to why a person can't stop eating or can't lose weight. If they are a bit more chubby, maybe they are not as motivated. We also have an exercise physiologist. We have a dietitian. So when a patient comes to a metabolic clinic, they would see all these specialists and we would try to encourage them to lose weight. What is the, how much weight should we lose? We can't get them to lose weight too quickly. Some people go out and just buy some shakes that will lose weight, and that would sometimes accelerate steatohepatitis, which is very dangerous. So we often say maximum 1 kilogram per week, about 7 to 10% of their weight in 12 months. We want them to be deficit in terms of caloric intake as well, about 500 to 1,000 kilocalories deficit per day. And I often ask them to exercise 30 minutes a day, 5 times a week. They don't need to go to the gym. They don't need to have an exercise bike at home. What they need to do is with their partner, with their wife, with their children, they go out to their taman and walk and sweat a little bit for 30 minutes, 30 minutes a day, 5 times a week. And that would hopefully try to improve their weight. So some people, again, a study has been done to say that once we manage to get the weight off, there's resolution of steatohepatitis in up to 90% of the patients. Liver fibrosis would improve in 45%, and also resolution of steatotic liver disease up to 97% as well. So weight loss is a very, very good way to try to reverse this. But not always we can do to lose weight. It's very, very difficult. I personally know that as well. I've tried to get some weight off, and it's very, very difficult.
Sorry, so fibrosis, I mean, if we understand the word fibrosis is like scarring.
Correct.
But by losing weight, liver fibrosis seems to be reversible. So is fibrosis in itself, the term cannot be termed as scarring, right? Because scarring is like not reversible.
So the scarring could, I mean, I usually use scarring as a word to improve the understanding of this condition.
Okay.
So I guess if somebody hears scarring, they might get a little bit more afraid and they may want to change a bit better. But as we discuss fibrosis in the earlier stages, it's dynamic. So it's still dynamic.
Yeah.
Yeah. And
because if we take it literally, fibrosis as scarring, like what we learn in medical school, but it is reversible.
Yes. Yeah.
It's like
in the earlier stages.
Yeah. So it's true. I mean, you can also reduce what do you call that? The scars. Oh my God. What's the name of the big scars that we see on the chest?
Keloid.
Keloids, yeah. Oh, my jet lag is getting to me. So yeah. So yeah, we can also reduce. It's basically, I think, reduction of inflammation, maybe.
Yes, correct. Exactly right. So I feel like the liver is the best organ ever because it's a very forgiving organ and it can repair itself up to a stage. So it's a great pleasure to be a hepatologist, actually.
Oh.
So moving on to a pharmacological agent, because so far we've tried a lot of medications, but nothing really definite to say that this medication can reverse fibrosis and also can reverse MASH. Apart from weight loss, there's no medication directly to reduce the inflammation and to reduce fibrosis. But again, all these clever people did a study. They name it Maestro study. And they looked at this medication called resmetirom, which is a thyroid hormone receptor beta agonist. They found that in the liver, they've got all these little receptors. So they designed this drug to directly act on it. So this is an ongoing study. So they've done phase 2 trials, phase 3 trials. They've published quite a few papers. This one is the most recently published one in February this year, New England Journal of Medicine. So a very highly cited, very highly read paper. It's a very good paper. They look at 966 patients. They all had a liver biopsy to confirm that they have MASH. So remember, not all patients would have MASH, but these ones specifically have MASH. This paper reported outcomes at 52 weeks, 1 year. So you can see that resolution of MASH was about 26 to 30% compared to 9.7% in the placebo group. So it's very significant from 10 versus 30%, very, very significant. They also looked at fibrosis staging, so the improvement of one stage of the fibrosis score. So maybe F2 to F1, F3 to F2. I can't remember if they included F4 patients as well, but basically there's marked improvement compared with placebo, 24.2, 25.9% as compared to 14%. The safety profile is also very safe. The most common side effect was GI side effects, nausea and diarrhea, up to 33%. Obviously, there's a higher percentage of discontinuation of the medication because the side effects in the higher dose, 100 milligrams. But the lower dose, 18 milligrams versus placebo, is no different. And the discontinuation rate was about 2%. So this medication is FDA approved. That's the only FDA approved medication to treat MASH. And it's currently available in US. It's not in Malaysia yet. I think it's a very, very expensive drug, obviously. So we will watch that space as to how effective it is. The caveat is for FDA approval, they have to have proven NASH. So all the patients would need to have a liver biopsy to prove that these patients have MASH before they can prescribe this medication.
Was there a reduction in weight in all of these patients? Did they look into it?
Very interesting question. I don't recall looking at the outcomes of their weight, but they would have, that's a very important point. If they've lost weight already, then obviously the regression of the fibrosis and MASH would happen as discussed earlier. So I can't remember if they looked into the weight from memory. I think they didn't report that. But that is a very, very good point.
Thank you. But it's also because then is how you call it? It's beneficial in many aspects. But if it's just basically targeting liver, then we will still be ending up with patients with other related, other complications that's related to being overweight.
Correct. So this one is just the liver.
Okay.
So Betty's concerns will be cardiovascular disease as well. So there are many recommendations out there. And so we recommend in terms of lipids in the moderate or intermediate risk patients. So those are the ones that we would see most often in the primary care setting. The LDL should be less than 2.6. The triglyceride should be less than 1.7. So I'm not sure, maybe Betty is a bit more gung-ho in starting higher doses of statins. I usually go very slow and a bit cautious because I see the other end of patients coming in with cholestatic hepatitis, even though very rare. But I still get a bit cautious.
Don't scare my patients, please.
But they are very safe. So they've also put a little thing here to say that even though they might have mildly elevated liver enzymes, for example, the ALT and AST, which is not uncommon in these patients, would have a bit of a blip in their ALT up to 100. If their ALT is less than 100, then we are very safe to start statins anyway. So we don't really need to wait until their liver enzymes are normal before we start statins, because these patients actually do need statins to prevent all these complications. So if their ALT is less than 100, which is 3 times the upper limit of normal, then we should already start them on statins.
Go back to the previous slide, please. I want to emphasize what you have double asterisk there, that fibrates do not improve CVS outcomes. And that's so important because some endocrinologists so much, favors fibrate over statin for some reason or other.
Oh, right, okay.
I cannot understand that. So please, everyone, take note of this double asterisk here. It's a very important thing to note here, yeah. Okay. It's very important. Thank you.
Yeah, Betty, I don't use it that much, but I remember seeing a patient who comes in and tells me that she's very bloated, farting a lot, and whether that's related to fibrates, I can't remember
No, I
side
don't.
effects of fibrates.
I do use it, and I use it in combination of statin,
Mm,
because sometimes I can't control the triglyceride, and there are the triglycerides. We're talking about not 2 or 3. Sometimes it's 11 or 7.
mm,
Yeah, but I find that endocrinologists tend to favor fibrates because you see they see a lot of diabetic patients. And of course, when the diabetes is not well controlled, the triglyceride will be increased too. So they will start fibrate first before statin, and I really can't take that.
okay, so
Can't
we've got to encourage each other to
Yeah, that's
stop the
right.
statins.
Yes. I think the GPs are the best people to actually fight. You know, they are like the first people to fight this overweight war, this obesity war,
Tsunami.
tsunami. Yes, they are the first. Okay, at
Yeah.
every chance you have, speak to every single patient. Follow that few steps that the UPM metabolic clinics are doing. Yeah.
Mm.
Okay.
So we also have blood pressure targets, less than 130 systolic and less than 80 in diastolic. Obviously, if they've got chronic kidney disease, ischemic heart disease, heart failure, then the angiotensin receptor blockers will be better, or ACE inhibitors as well. If somebody is diabetic, then we have to target their HbA1c to be less than 6.5%. In the past, we thought PPAR agonists were a good drug in patients with MAFLD and diabetes, but obviously we are a bit concerned about heart failure, bladder cancer, and fracture risk with pioglitazone, and previously even more so with rosiglitazone. So PPAR agonists, we're currently not using it that much. But the next two ones, I'm sure you have come across these medications, the GLP-1 receptor agonists like semaglutide and liraglutide, are famous for their weight loss. And then there's the SGLT2 inhibitors, which are empagliflozin and dapagliflozin, that's available at the moment. This one's my Betty probably uses quite a lot. My nephrology colleagues as well
Yeah,
advocates
it's
for
like
this
a wonder
medication.
drug of today.
Yeah.
Yeah.
So SGLT2 inhibitors are
In actual fact, we don't know the real reason behind some of its benefit, but I suspect that because it makes us pass out sugar, the level of glucose in our cells, okay, is less, and somehow that is the benefit. Means the level of sugar. I also don't know how it benefits the cardiovascular aspect, especially in heart failure. We're not talking about the vascular as in the coronaries, but even in heart failure. I find it very interesting. Okay. Yes.
So this summarizes everything lah. So I've just highlighted this GLP-1 receptor agonist. And you can see that it reduces liver enzymes, liver fat, liver fibrosis, MASH resolution, body weight, and has cardiorenal benefits as well, actually. Whereas SGLT2 inhibitors, definitely cardiorenal benefits, but we still don't know about their MASH resolution and liver fibrosis. I'm sure one of the pharma companies came up to me recently to say, actually, there are some papers out there that's starting to show some improvement of liver fibrosis. I mean, I haven't really had the chance to have a look at that. But again, SGLT2 inhibitors are a very, very good drug. There are more drugs coming out, the GLP-1, GIP receptor agonists, the combined medications. There will be a lot and a lot and a lot of new medications coming out for treatment and management of metabolic-associated liver disease.
But
So again,
SGLT2 doesn't reduce weight as much as the GLP-1.
correct.
So that's probably why you still don't it's not so obvious your reversal of the liver fibrosis on MASH.
Yeah, that's true.
Yes, possibly that.
Yeah. So how about other liver tonics? So some patients would say, I don't want to take medications, I'm happy. They would have all these concoction and over the counter, they want to buy supplements. So there are studies out there to look at vitamin E. In the past, they worry about high doses of vitamin E with complications, but we do in our MSGH guideline, they do recommend 800 international units of vitamin E. Silymarin is the other liver tonic, the brand name Legalon, if you're more familiar with that. Curcumin or turmeric, pre and probiotics. Unfortunately, there are no big studies to look at this, so I can't really give you real hard evidence to say this is good, definitely take this. But the rest before this, they have good hard evidence in terms of the hypoglycemics, the lipid, the statins, the weight loss management. So all those have hard evidence. When do we request for our surgeons to come in? In the past, we say BMI 35 kilograms per meter square and above, plus complication of obesity. Then we would say, okay, it's less likely that you would make changes to your weight without a surgery. Then we would recommend that. But nowadays, a bit not very common because of these GLP-1 receptor agonists, because their weight loss is quite rapid and they probably don't need bariatric surgery if they continue on that medication. So when to refer, obviously, if the patients have significant fibrosis, I would say that if your FIT4 score is 1.3 and above, and if you have the luxury of having a liver stiffness measuring device in your clinic or in your center, you do that. If the patient has significant fibrosis, liver stiffness measurement 15 and above, they need to be referred on. If the patient has liver cirrhosis, obviously, either compensated or decompensated liver cirrhosis, please refer them on. Obviously, if they have HCC on their ultrasound scan, refer them on to us as well. So in summary, I think we have to stay very vigilant because it's getting much, much more common. 50% of us are fat. We have to actively screen at-risk patients, obese patients, diabetic patients, patients with metabolic risk factors. We use an ultrasound for diagnosis because we do, if you remember that diagnostic criteria, we have to confirm that the patient has fatty liver on ultrasound scan. Although ultrasound scan is operator dependent, and also they can only scan if their fatty liver index is more than 30%. There are some caveats there, so it's not a perfect test, but still it's a good screening test out there. Once you feel that this patient has MESO-D, then you calculate their FIT4 score. If you have liver stiffness measuring device in the center, great, do that as well. We don't advocate for just one test. So for example, we don't advocate for just doing the FibroScan or liver stiffness measurement. We try to make it a bit more cost effective. We do FIT4 score first and then jump to liver stiffness measurement. In terms of management, the pillar is still diet and lifestyle, weight loss management. There are some medications out there, and we've gone through all the targets of how to what to give, how to target their different metabolic risk factors. If the patient does not have significant liver fibrosis, you can have a look at them, monitor them every 1 to 2 years, repeat their FIT4 score 2 to 3 years. and see whether they have made any changes to their lifestyle, and hopefully they would get better and more confident. But if they've got significant liver fibrosis, cirrhosis, or HCC, then refer on. I was very lucky that Prof. Rose gave the permission for me to put this slide up because she's in the process. Yeah, yeah. So Prof. Rose and the higher stakeholders are trying to incorporate this and make the government aware that this is a true problem, the non-communicable diseases side, to say that we have to do something about this. So they have come up with that slide, and they have tried to make it as simple as possible, and to try to screen for MEFOD or MESOD. I think we've got to change it, and risk stratify them in the community. So for those who are at the lower risk, these ones can be managed in the primary care, because of course we don't want to overload the secondary and tertiary care centers as well, and they are all very busy already. And for intermediate and high risk, then consider referring it on for further investigation or management. They also put here that we don't forget to screen for other causes of chronic liver disease, because again, the more insults to the liver, they may have 2 different problems or 3 different problems. They may not just have one fatty liver disease. So we always have to screen for hepatitis B, hepatitis C, ask them whether they take any alcohol or have any harmful use of alcohol, those kind of things, to make sure we improve their liver and manage their liver aggressively. It says aggressively manage their metabolic risk factors and cardiovascular risk factors. Okay, I think that's my last slide.
Okay. So I think we take some questions. Dr. Chi Chai from Doquity asks, what's the risk of statin on metabolic health of the liver?
I think statins are good for the liver. I mean, we ultimately want to reduce their metabolic risk factors. So statins, we would try to reduce the risk for cardiovascular diseases. So I think statins is good for the liver. I think what you meant is, where are we worried about cholestatic hepatitis with statins? It's actually not very common, and we don't screen for that. We don't actually ask the patient to have a liver enzyme test within 3 months of starting a statin. We just monitor their symptoms. If they're unwell, if they notice yellowness in their eyes, then we say, okay, this is getting serious. You need to get a blood test.
I think 30 years ago, we may have been worried there may be an increased risk of AST and ALT, but this doesn't imply that they are going into liver failure or liver dysfunction. And so 30 years ago is when statin started, so we were worried, but now we have used statin for 30 years, thereabout. Yeah, so I think that no one should have any doubt about statin. No one. Okay, not the doctors. And if there's any doubt about I'll take away your medical degree. Okay.
So interestingly, recently also we noticed that patients with MESOD and cirrhosis, for example, child A, liver cirrhosis, compensated cirrhosis, we often give them statins also. Something about preventing decompensated cirrhosis.
Really?
So yeah, so statins
I'm so
actually
glad
quite good
for
for the
this
liver.
talk. I mean, I want so much to promote statin. Okay. Because as much as you see, as much as people with heart disease has paid for my children's education, I don't need it anymore because they've all been educated.
Understand? Understand.
So, Dr. Rose asks, how do we refer patients to UPM Metabolic Clinic? Does it need specialist referral or a GP referral is okay?
So nowadays we are trying to do everything online. So there's a patient portal system for Hospital Sultan Abdul Aziz Shah. So often patients can log on to it, take a picture of their referral letter, and then put it on there, and it will be channeled to the different departments. So it is named as Metabolic Clinic. So you can write a referral letter to the Metabolic Clinic. The waiting list is a bit longer, obviously, because there are a lot of patients. So they may have to wait about 3 to 6 months before actually being seen in the Metabolic Clinic, which sometimes defeat the purpose, but there's just too much of a burden.
I think it's very important for you, everyone, for every single doctor to see what UPM offers to the patient, and almost all of it. It's not like UPM is exercising for the patient. It's not like UPM is dieting for the patient. No, they're just advising the patient exactly. And those advice can come from you or me or anyone. So don't worry about this referral. Just start advising everyone, even yourself.
Yeah. And start giving statins, and if you have the luxury of all the hypoglycemics that we mentioned just now, then if you're comfortable starting, just start already.
Yeah. So a statement from Dr. Shah, yes, 54.4% of Malaysians are overweight. And that was the census last year. 54.4%, you know. Does all transaminase, wait, hold on, does all transaminitis patient, okay, is that such a word, require ultrasound? What's the criteria indicated for ultrasound?
So I would often screen for any cause of hepatitis. So when I say hepatitis, is inflammation of the liver. So if you have increased liver enzymes, AST, ALT, or other cholestatic enzyme, ALP, GGT, the things to do is to screen for any cause of liver disease. So viral hepatitis screen, and also an ultrasound scan, because you never know whether they have fatty liver or whether they have a liver lesion. So I would do both a blood test to see whether there is any viral hepatitis, and then do an ultrasound scan to look for any liver lesions or fatty liver changes.
Okay. Sham said, can I have the link? No, go and Google it yourself. When do you send patients for ultrasound elastoplasty for steatotic liver? Oh, I'm glad I'm a cardiologist.
So if you when you calculate your FIT4 score, that is more than 1.3, then you can ask your radiologist or sonographer to see if their ultrasound machine has the additional software, because not all ultrasound machine would have shear wave elastography. They either need to be bought extra add-on software, or the newer ones may already have that software included. So you have to ask your radiologist whether they have that software. So I would only do it if I suspect the patient has liver fibrosis, in which case FIT4 score more than 1.3.
Can you have fatty liver without increased enzymes, liver enzymes?
Can.
So would you do a ultrasound or suggest an ultrasound for everyone that is overweight, or everyone at all? Because
not everyone.
But because there is lean fatty liver. I use the word fatty liver, please excuse me. But there are people like that. And I asked you whether age is one of it. But because the last ultrasound I did, the radiologist said that I may have fatty liver. But maybe I drink a lot.
Ah,
Yeah, oh my God.
between you and
Just
me.
thinking. Yeah, I see.
So fatty liver, so there's no hard evidence to say that anyone who's lean need to be screened because if you remember, research is in a way that's designed that is not a population-based screening. So unless it's a population-based screening kind of study, then you might be able to take that evidence. Sometimes research, they just look at one cohort of patients. So they may have, they may not be lean, but maybe they have increased waist circumference, maybe they have insulin resistance. Then they screen those patients and they found that they have meso-D. So we have to take it into context. So personally, I still would not screen everyone. Obese patients, yes. So in our metabolic clinic, when they come through the clinic, they would have an ultrasound scan and blood tests. So yeah, purposeful screening.
Okay, how if ALP is abnormal? Need to screen too?
So alkaline phosphatase is a different enzyme. It's a cholestatic enzyme. So ALP needs to be looked at with GGT. Because ALP is not only from the liver, but it's also coming from other places like the bones. So in a growing kid, the bones are expanding, so their ALP will be raised, but their GGT will be normal. So if the ALP is raised but normal GGT, you have to think, is this coming from the liver? Chances are it's not. So you have to look for a bone disease or any other things lah.
Can I ask, since you mentioned GTT, because these days a lot of people do health screening and GTT is included, but everything else is normal, but GTT is abnormal, but they're not drinkers and they have no signs of liver infection. So what is the cause of this increased GTT? I don't know how to explain to my patients.
It's a very sensitive marker for fatty liver disease also.
Oh, I see.
So if your patients have metabolic risk factors and they have raised GGT, then we have to think, does this patient have metabolic dysfunction-associated steatotic liver disease?
Oh, I see. Okay, I'll take that into consideration. So, Miss Dr. Tanggala, okay, last question, yeah, because Dr. Tanggala asked 40-year-old male Down syndrome, ALP 687, GTT 478, ultrasound normal. Wow,
Very interesting.
very.
Again, ultrasound's not the best test. You may have to look at other things lah. There are autoimmune problems out there. For example, primary biliary cholangitis could cause the ALP to be high. So you have to do autoimmune markers. Primary sclerosing cholangitis also can cause ALP to be high.
Wouldn't the bilirubin be high then?
Not necessarily. Bilirubin would be high in the context of obstruction, complete obstruction, or if the liver fails lah. But a lot of things can raise the ALP and GT. Medications also. If Down syndrome, I don't know whether they would have epilepsy, in which case they can be on anti-seizure medications. The other thing would be heart. If Down syndrome, whether they have congenital heart disease, heart failure, liver congestion.
No, I don't agree. The heart usually, if liver congestion, the ALP, the AST and ALP will go up first before the A. Have you repeated the test? Dr. Tanggala, please repeat the test if you have not repeated the test. That's my first thing. Because interesting. Okay, we will end this session. Thank you very much. Suyin, so next year I'll invite you back. We'll find some more topics to talk about, definitely. And the other thing is, I want to say that you are an extremely good and teacher, very clear and very enthusiastic in your
Thank you.
teaching. And I want to say that UPM is very lucky to have you. Yeah,
Thank
you
you.
are a very good teacher. Thank you very much.
Thank you. Thank you,
Guys,
Leslie.
see you
Thanks.
next week. Next week, we're actually doing randomization in a clinical trial. So
Oh, wow.
yes,
Okay.
my friend who is a cardiologist, Dr. Damaraj, he just finished his master's from Oxford
Well
on
done.
statistic or data. I'm not sure, but yeah, let's join us. I don't know what is it about, but okay. See you guys. Bye, everyone.
Thank you. Have a good night.
To try to sleep. Thanks, Asuin. Bye, everyone. Thank you so much.
Bye. Thank you.